Good afternoon. Welcome to Workshop 16 of the 6th International Conference on Law Enforcement and Public Health. My name is Roland Lamb. I'm Deputy Commissioner for the City of Philadelphia's Department of Behavioral Health, and I am both proud and honored to be moderating this session. We've got, 4 great speakers that I need to really hurry up and get to right now so I can give them all the time that they need. Our first speaker is going to be Dr. Talid El-Sababwi, who is an interdisciplinary scholar with a Juris Doctorate from the University of Texas School of Law and a PhD in Public Health and Health Services Management and Policy with a doctoral cognate in Political Science from The Ohio State University. She is co-authored a model of law that creates non-police behavioral health crisis response teams and has been assisting grassroots advocacy groups in developing narrative strategies to garner political support for the reform of institutions that perpetuate racial violence. Dr. Sababwi is on the board of advisors for the North Carolina Urban Survivors Union, a chapter of the Urban Survivors Union, and frequently works alongside persons who use drugs advocating for policy reform. Dr. Talid Sababwi is a scholar with the Addiction and Public Policy Initiative at the O'Neill Institute. She will be discussing a service initiated in Ontario that collaborates with community services and healthcare providers to identify individuals deemed vulnerable and proactively connect them with services they need before they reach the crisis situation. I introduce you to Dr. Talid El-Sababwi.
All right, I'm going to share with you my screen today. There was a little mix up with the abstract. So I'll actually be talking about the evidence-based law, and then my wonderful panelists that are coming up later will be speaking about the services in Ontario. So sorry to disappoint, but let's get started. All right, so through this conference, there have been a number of references to the deaths of George Floyd and other persons, and that discussion has been coupled with a need for this alternative response to police responses. But despite acknowledging the need, my slides are getting away from me. Despite acknowledging the need, it's pretty taxing and difficult to convince policymakers to adopt these types of solutions. And it's even more difficult for policymakers to come up with the language to use in executive actions or regulations or council ordinances, right? So based on our experiences working with both community organizers and local policymakers, we provided them a number of technical support on how to create these types of programs. We created a model law that can be adopted at the city, the county, or the state level. This model law, we circulated it widely amongst grassroots groups, public health scholars, and mental health and addiction policy scholars. And in drafting it, we specifically spoke to people who use drugs and people with serious mental illness, persons from immigrant communities, and persons who've experienced housing instability, among other groups. And based on that, we did 2 things. We drafted a paper and attached to it a model law, and I just shared it with you all in the chat so you can access it if need be. In this model law, things going on at once. Okay, our paper goes over it provides the evidence that grassroots groups need, the empirical evidence, but then it also discusses the types of policy proposals you can make, implementation decisions, and as well as what is in the law, why it's in it, and how you can customize it. Today, I'm going to focus on parts 4 and 5 because I only have 8 minutes left, right? But I encourage you to visit the link that I shared with you all if you want to access the paper. So just quickly, in part 3, we do talk about crisis interdisciplinary teams. And these are interdisciplinary teams, often called co-responder teams, where a mental health provider or social worker rides alongside law enforcement to calls. These are very popular programs, but we really did a really deep dive into the empirical evidence, and it does not show any evidence, any empirical evidence that it improves outcomes for the person experiencing the crisis. So it might help law enforcement feel more confident. It might help law enforcement's mental health, but it doesn't actually help decrease the excessive use of force against persons experiencing behavioral health crisis, nor does it improve outcomes. Sometimes it increases excessive use of force, and it can increase the number of involuntary commitments. So that, alongside with statistics we have from Cahoots, which shows that 150 calls out of 30,000 were all that was needed, where police backup was needed, that's less than 0.5%. Really, we push back against this idea that people with behavioral health crises are violent or dangerous, and that law enforcement needs to be there to protect the clinician. So if you're interested in that, I invite you to look at the paper. That's not going to be the focus of my last 6.5 minutes. Instead, I'm going to talk a little bit about what our model law looks like and why we included what we included. Okay, so this model law is based on Cahoots, and we did interview folks from Cahoots when we created this model law. And Cahoots, I'm sure you all are familiar with it, so I won't spend too much time. They've operated for over 2 decades providing non-police response to persons in crisis. Why Cahoots? Well, there's evidence that it saves money, which is appealing to conservative policymakers. Also, it's shown a great deal of success. But those of you who are familiar with the program might push back and say, well, it's Eugene, Oregon, and it's associated with the White Bird Clinic. So we have a very liberal governance in that particular area, and a federally qualified health center that has been there for decades. And we acknowledge that places don't necessarily have that. Like, we live in Greensboro, North Carolina, and we don't have that same infrastructure that they do in Oregon. So we instead decided to base our model law on Cahoots, but make some tweaks to it. And we also made sure that it complied with SAMHSA's recent guidelines on emergency crisis response. So what we call it a behavioral health crisis response team, and we shortened the acronym to BHRT. The team has, here's how it works. Here's a quick overview. So an emergency call operator may receive a call, may start there. And for calls related to mental health, substance use crisis, or general houselessness, a BHRT team will be dispatched rather than the police. Now, a second way that this BHR team could be sent is that they could be called directly through a direct phone number from the public. And the third way the BHR team could be activated is by law enforcement, who, when they encounter a person experiencing a behavioral health crisis, they call the BHRT to come respond. The BHRT, it is the dispatch team here that has an EMT, which can be, which really focuses on administering overdose reversals and rendering any first aid that may be necessary. Then we have a trained mental health crisis counselor. Now, we want to make sure that we're clear here. We're not talking, you could even call that a mental health crisis worker. We're not talking about an actual counselor or clinician. There was a lot of pushback when we spoke to persons with serious mental illness about sending clinicians out to respond to these calls. There was a lot of fear that there would be a lot of involuntary commitment, and it was just a form of coercive outpatient treatment. So we took that feedback, and Cahoots, made it similar to the Cahoots model, where it is somebody who's trained in behavioral health de-escalation. That is our focus: de-escalation of the crisis, stabilization, and determining if a higher level of care is needed. If it is needed, then a clinician can be brought in, or the person can be transported. We also added a third person, and this is unique because it's not in the Cahoots team, and that's a behavioral health consumer. I recently heard about Philadelphia's new program. And rather than having a clinician, they decided to send out a peer. And this is a behavioral health consumer is similar to an idea of a peer support, but it's a person with lived experience in the behavioral health care treatment system. We avoided using the word peer because in some states or in some jurisdictions, peer specialists are actually a professionalized role that is codified in the statute, and they have to meet certain professional expectations. So we envision this to be a true peer. And the primary role of this behavioral health consumer is really to ensure that the person is in crisis is treated in a supportive and empowering way and is given agency over themselves. So to ensure that there is no coercive treatment of that person. So the act, I'm not going to have time to go over a lot of it, so I'm going to skip much of it. I do want to point out a couple of things that also make it unique and amenable to jurisdictions where there might be fear that law enforcement lobbying group may co-opt this program, or that provider lobbying groups might co-opt it, and it might become just another form of coercive involuntary commitment. So we put in the act that it would not be administered or staffed by law enforcement, and that there would be a consumer-led advisory board, and that advisory board would be in charge of a number of, okay, here we go. They would work with the government office to create the program and oversee it so that all the protocols, procedures, and so forth were done in a way that was responsive to the community that it was responding to. And here we do strongly recommend getting in contact with Cahoots because they now offer technical assistance and consultation that can be provided to jurisdictions looking to set up these programs, where they'll help you create the protocols and procedures. They'll help you train the people who are the mental health crisis workers. They'll also even help you write up some grants to get some of those upstart costs offset. So we greatly encourage seeking their help. Let's see. Anything else I can go over very quickly? All right, so other important points in the last few seconds that I have left is that we do want to make sure that it is not coercive treatment. So we highlight that it's important that the person be asked, if possible, be asked if they want to be transferred to treatment, and that they be provided with different treatment options, different types of treatment. We require them to carry overdose reversal medication. And this was a big concern of persons that we spoke to, that they did not want to have to provide their name. And so we put that in the act to make sure that they would be able to remain anonymous and still receive services. All right, well, that's my time. So if you all have any questions, feel free to reach out to me or my co-author, Dr. Jennifer Carroll. We would be happy to share any suggestions that we have. So thank you.
Thank you, Dr. Zimbabwe. We are, find this most interesting and would like to follow up with you on this, what we're talking about this afternoon. For our next presenter, I want to present Rachel Bloomberg, who has a guest with her, Asante Houghton, and they are going to speak on the area of civilian-led mental health crisis response service in Toronto as a replacement to police responses to nonviolent and mental health crises, as well as similar work that's being done in other cities. Rachel Bloomberg has been a coordinator of the International Mobile Services Association, which is a service providers network connecting individuals across Canada and the United States who are building civilian-led mobile crisis services in their communities. Rachel is a member of the Toronto Regional Human Services and Justice Coordinating Committee and the Center for Addiction and Mental Health Services Constituency Council. She is currently completing a dual degree in law and social work, and she has been working as a peer supporter and a peer educator for the past 7 years. That's a subject that's very close to my heart, and that is the advocacy and the support of peers. Asante Halton has emerged as a leader in mental health. As a veteran of the speaker circuit, he has presented across the globe. He also has firmly entrenched himself in a mental health space at large. He's now devoting his time and energy and focuses to the intersections of race and mental health, seeking to amplify the myriad of experiences of Blackness across the diaspora in order to shed light on the ways in which being Black in a world that seeks to diminish Blackness impacts on the mental health of Black people. He is also the designer, manager, and facilitator for peer support training programs at Stella's Place. I give you Rachel Broomberg and Asante Halton.
Thanks so much for having us today. So Asante and I are the co-founders of the Reach Out Response Network, which is working with the City of Toronto to build a civilian-led mental health crisis service here. So what I'm going to do today is talk a little bit about the work that's being done in Toronto, as well as some of the international models that we're basing our service on, including and especially Cahoots, which is my favorite model. I won't go into a ton of depth about that because our last speaker did that. But I'll say a little bit about the work that's being done in Toronto. So our city council voted in February to build a new crisis service that will have 4 pilots launching in 4 different parts of the city in January 2022. So what we've proposed is that the service would be staffed by mental health workers as well as peer workers from the communities they serve. And our hope, and what's in development right now, is that the service will be accessible via 911 dispatch as well as via its own separate number, and possibly also via 211. In the 4 catchment areas, the service is going to be available 24/7. And as the pilots are evaluated, the hope is that they're going to be expanded to cover the whole city 24/7 by 2025. So the idea is basically by 2025, when someone calls 911 in a mental health crisis or on behalf of someone else in a mental health crisis, rather than police being the default first responders, it would be a team of trained crisis workers that goes out, with police only being dispatched if there's a serious safety issue. And we know from 911 call data that that only really occurs in about 10% of mental health related calls. The majority of these calls really can and should be answered by civilian crisis workers only. Most of the crisis teams that have been discussed at this conference so far, as well as in the media and in research, are co-responder models that pair a police officer with a mental health professional. But the civilian only model that we want to talk about today, even though it's been less publicly known, recently that's starting to change, but it's been around for many years. It's been really successful in the cities it's been tried in. Cahoots, obviously gold standard, they've been around for 30 years. And as our previous speaker said, Cahoots has been working with lots of different cities, especially over the past couple of years, to build similar services in those cities. So in Olympia, Washington, a Cahoots similar program called Crew launched in 2019. Denver, Colorado launched a similar team in June of last year. San Francisco launched a similar team in November of last year. Portland launched a similar team last month. There are also a bunch of cities that are in the process of building similar teams that will be launching over the next year or two. So like New York, Chicago, Berkeley, Houston, Oakland, Sacramento, Chattanooga, Albuquerque, Los Angeles, New Haven, lots of different places that are going to be launching this model over the next year. So I wanted to talk a little bit about the model, some of the models that we've seen with Cahoots and with other services. So the way that Cahoots works is that it's a partnership between the Whitebird Clinic, which is a community health clinic, and the city or the public safety system. So basically the calls come in through the public safety system, like through 911 or the non-emergency line, and then a team employed by the Whitebird Clinic, Cahoots, responds to those calls. Some cities are using different models than that. Like rather than contracting with an agency to run the service, they're actually creating a new city department to operate the teams directly. So Albuquerque's doing that, Sacramento's doing that, Chattanooga's doing that. Because a lot of these teams are fairly new or haven't officially launched yet, like Albuquerque, for example, will launch in a few months. There isn't yet a robust body of literature on whether one type of model, like the agency model versus the new city department model, might be better than the other. From the research that we've done, it seems like both of those models have a lot of benefits and are promising in the communities that they're being tried in. But one of the things that my association, the International Mobile Services Association, is hoping to do, we have brought together all of the folks across Canada and the US who are working on these teams, researching these teams, operating these teams, building these teams, advocating for these teams. We have over 100 members at this point. And one of the things that we want to do is really build an evidence base for what is the best kind of model, or what works best in different localities, right? And figure out what are the best practices within this field. So it's still an emerging body of research. One thing that we have seen from the research that's really important is 911 integration. Teams that can't be accessed via 911 from our research and what we've seen just don't have the scope to answer the number of calls that right now police are currently responding to. And then police still end up being dispatched to a lot of situations where they might not be the best fit. And we know from the data that the majority of calls made to 911 regarding mental health crises are not actually made by the person in crisis themselves. We know that about 30% of these calls are made by family and friends of the person in crisis, about 30% are made by service providers, and about 25% are just made by bystanders who, they're witnessing something happening. They don't necessarily know the person, but they're like, something's going on, let's call 911. Those folks, they don't know a lot about mental health resources. 911 is often the number that they know to call. That's where they're going to keep calling. So it's really important to make sure that there's connectivity and collaboration between 911 and the civilian-led service. Like there is some education you can do on the front end to try to get people to call a different number, but it's a lot more effective to have multiple pathways and make sure that people who don't know about the other service are still able to access it via the methods that they're already using. I'll stop there for now and let Asante talk a little bit, but if anyone wants to get in touch or learn more about the work we're doing in Toronto or about the International Mobile Services Association, or if you're interested in building or advocating for a similar team in your community, please email me. I will put my email in the chat. Wait, can I? Yes, I can. And yes, Asante, go ahead.
Good afternoon, everybody. I really appreciate you being here. Thank you for being a part of this presentation so far. With all that being said, we don't have that much time left. So one thing I really wanted to talk about is how we are working with not only the city, but community members to make this happen in our city in Toronto. So a big part of our journey has been the community engagement piece, which has allowed us to effectively do needs assessments with regard to what community members are looking for. And then developing relationships with our city has also led to a place of us being able to take what is being spoken about and bring it directly to the city. So now moving forward, we're in a place where we are a big part of the implementation and what things are going to look like. And we're looking forward to things like training, and we're looking forward to things like, infrastructure and all of these different pieces. And, for us, what we have found has been useful beyond all the modeling that Rachel has talked about is the relationship building piece, talking to all of our city councilors to get a snapshot of what their constituents are thinking about and what they would like, and also helping to educate them about the model and things that we hope to see moving forward. So really doing a lot to gain momentum behind the scenes, as well as putting together a model and recommendations that we think will work within our city. So I don't want to take up too much more time because I know time is limited, but I did want to say that before we move forward. So thank you everybody for that.
Thank you both. I think again, this is some very interesting work and dovetails very nicely with things that we're doing here in Philadelphia. We want to make sure that we have some kind of mechanism to stay in touch with each other, because these are really grassroots initiatives that are in and of the community, and for that reason, I think that, and the fact that we have a focus on peers, that we need to have a much more conversation about this. So thank you very, very much. I want to now welcome Dr. Crystal Martin, who is a clinical and forensic psychologist and currently a research scientist at Ontario Shore Center for Mental Health Sciences. Her research is focused on the intersection between mental health and criminal justice. Dr. Martin holds an adjunct graduate faculty status at Ontario Tech University in both the Faculty of Health Sciences and Social Sciences and Humanities, as well as at York University, and currently provides supervision on several graduate students. Dr. Martin will be describing a proactive program in policing that partners a police officer with a nurse. This program aims to support individuals who are identified as being vulnerable and prevent unnecessary criminal justice involvement. Dr. Martin.
Thank you so much. So yes, everyone, my name is Crystal, and I just wanted to let you know that I created a video of my talk so I could manage that in case I had any technical difficulties. But just to highlight, and I do indicate this in the that I'll be describing, is a proactive approach. So it is not one that is a response, like the other presenters are talking about. And it really I'm just going to share my screen and hope that that works. Just a second. Okay. See, I thought this was going to be helpful. If it doesn't work, I do have my presentation. Okay. So sorry, just a second. I'm going to go back and share my screen with my actual presentation, which I will now give instead of my recording. So like I said, the project that I'm going to be sharing is called the Vulnerable Persons Project, and it was a police public health partnership. So it is that co-response that others have mentioned. But instead of a responsive program, like I said, it was a proactive program. So again, just some context that we know that others have mentioned, and that most folks coming to this conference know about, is just that significant number of folks with either mental health or substance use issues coming into contact with police, that they're more likely to be arrested in those contacts, that we know that police are often that first point of contact and entering into accessing resources and support, and often contribute to folks who are doing repeat calls for service. We know, of course, and rightly so, that there's been this public pressure to improve police response to individuals in mental distress. And so, like some of the other presenters today have described, there are various solutions or problem solving that police services have done, such as crisis intervention teams, the street triage, co-response, or, like we heard from our previous speakers around non-police response as well. So all of these together really did influence the initiative that the service that I'm going to be sharing about came together for. So to just give some context, we are located in Durham Region, which is part of the Greater Toronto Area, which is just east of Toronto in Ontario, Canada. Our area has a population of about 700,000. So Durham Regional Police covers the whole area and has an approximate size of about 1,200 staff. They do have a program, a mental health support unit, which does pair nurses from our local hospital with specially trained police officers who have training around mental health knowledge. But this was a special program that was created out of a grant, so a provincial grant that used these teams in a slightly different way. So rather than responding to calls and supporting frontline, what they did instead was acted in a proactive manner. So folks were identified, and I'll talk about where those referrals came from in a second, but folks in the community who perhaps were identified as being vulnerable. So that could have meant having a mental health difficulty, substance use, housing issues or homelessness. Perhaps it could have been a senior who was experiencing neglect or harm. So individuals were identified in the community and referrals were made to this team so that this team would then go out and connect with those folks, with the idea that efforts were really made to try to connect these folks or reconnect them to services in the community so that perhaps we could prevent criminal justice involvement. So this project just ended as COVID was starting. And so at this point in our review or evaluation of the program, I just wanted to share those preliminary results of who this program served. And then we'll go from there. So in terms of that population that was served, there was 182 unique individuals. So there was many contacts with those individuals, but 182 separate people. In terms of gender, you can see the differences there. So 21% male, 48% female, and 31% missing. And if anyone has tried to collect data from police services, that sometimes, there is missing data or quality issues. So that is where what we also observed here. And so that is reflected in the age ranges of folks who were supported as well. So again, the majority of adults, some younger than 18 and some elderly folks. And then, like I said, in terms of referrals, you can see that the majority of referrals came from internal sources. So this was officers or frontline staff who had gone to calls, who perhaps had identified when they were at a call that there was someone who could use extra support or needed follow-up. So that was where the majority of referrals came from. In terms of what I've called follow-up here, this is actually officers in the mental health support unit following up people that they had specifically gone to in a reactive call. When I say proactive here, what that meant in terms of referrals is that sometimes officers would, or this team would go to areas in our region. Perhaps we had a tent city for a while in Oshawa. And so this is that team going and walking around specifically in those areas. And then some of our referrals came from the community. So when this program was launched, there was a lot of effort to connect with community services and the stakeholders that we already were partnering with, to have them be aware of this program, to lean on us and rely on us and sort of have a bi-directional engagement. And so certainly some of the referrals came from some of the community services. In terms of the reason for the referral, it wasn't necessarily unique groups. There was definitely overlap, but most of the time folks were identified as having issues around mental health, and then substances, homelessness, and other. And like I said, an other that could be something like a senior who needs extra support. What we found when we looked at the data, that upwards of about 50% of folks had already accessed community services in the past, and that it was somehow that they either were not maintaining those connections or not connecting with them enough. And so, as you can see along the bottom, those were the interventions that this team provided. So most of the time, you know, they were really providing verbal support to these folks. About half the time, they were again trying to reconnect them or help support them connect to a resource. So that might mean actually calling, you know, a community worker on their behalf, or it could be actually driving them somewhere and facilitating that connection again. About 22% of the time, they were providing practical support. And what I mean by that are things like providing food or clean water, or things like hats or gloves or boots. About 12% just merely information was being provided, again, about those community resources or something about services that could be helpful to them. And then about just over 5% of the time, they were actually, you know, taking them and supporting them to connect to a new resource in the moment. So actually on the call, you know, like I said, either driving someone somewhere or supporting them by phone to connect to a new community resource. So in the future, so VPOP, this Vulnerable Persons Project, like I said, was previously supported by a provincial grant, and so that has now ended. The Mental Health Support Unit has decided that instead of having, again, the separate program, that they have sort of swallowed up this program and by expanding this mental health support unit. So there'll be more of these officer nurse teams who will now be able to both you know, engage in that reactive support to frontline officers for calls, but also continue this proactive engagement of folks in the community as, again, to try to catch them or support them and connect them to services before more serious involvement in the criminal justice system. And then certainly we want to look at impact, you know, in a variety of different ways. We have been able to conduct interviews with our community stakeholders to get their input on how that relationship worked with our VPOP team and our mental health support unit teams. And the intention is also to connect with service users, so people who were supported by this program, to see how that experience was. So again, I'll stop there. So it looks like we may have some time for questions for the panelists, but I appreciate your time today. And if you want to connect, I will also leave my email in the chat. Thank you so much.
Thank you, Dr. Martin. Again, some very interesting material, and hopefully we have a chance to explore it, you know, further. But at this time, we do have a chance to have for folks to have questions. And so if we do have questions, do we have them in the chat, or where do we have them, Rushit?
You can have them on the Q&A panel, or you can have them on the chat. It's up to the
Okay, let me see here. I don't see any questions on the Q&A. So let me take a look at the chat. Okay. I don't see any questions. Oh, here we go. Dr. El Sababwe, have you seen any places that have successfully implemented a consumer-led advisory board yet?
So there are there's a whole bunch of literature on consumer-led advisory boards, particularly in the context of looking at police misconduct and so forth. As far as this particular context, I have not seen anything about that. What we did to come up with the best practices for the consumer-led advisory board was we looked at what had been done for spaces, looking again at police misconduct, and tried to build in some protections so the problems that arose with those types of advisory boards didn't crop back up. So, for example, there's term limits that we set so people will funnel in and out. There's an application process, and we try to recommend the types of categories of persons that should be represented to help with it. So yeah, no, we haven't seen anything in our context, so it's novel in that sense.
Okay. By the way, these questions are even though I'm asking them live, they are looking for some kind of typed answers for those questions. So we'll see how we can make out getting information back to people. Jason is asking, hey Rachel and Asante, can you share more about the input from BIPOC, LGBTQ, deaf communities, and others? That's really important piece that I think Toronto Reach Out Response Network have been leading on.
Yeah. Asante, do you want to take this one, or I can? I'm happy to.
I could jump in. For us, Toronto is a very, very diverse city in a lot of different ways. Whether we're talking about race, religion, gender, sexual orientation, ability, etc. So for us, it became very important at the very beginning to establish that what we were seeking was to make sure everybody was included in the process. And that became a huge part of our community engagement, but also our advocacy whenever we were talking to those who have power in government or those who have power in healthcare or even in the media. We definitely kept those things at the forefront, but we didn't just talk about it, we be about it to, go there, right? So in saying that, we made very concerted efforts to engage with a variety of different groups. We made concerted efforts to engage with Black folks, to engage with Indigenous folks, which, y'all might call Native Americans in the States, that sort of thing, to engage with folks of differing abilities, to do this kind of work. Because we knew that it was important in order to make sure that we were not replicating systems that have harmed people in the past as we introduce a new option and a new thing. And that, despite where we are in our process, that is not where we're going to end. Our intention is to continually get feedback from all people, but emphasizing, vulnerable communities, or what I like to say are equity deserving communities, to make sure that those folks are represented in the process of, from the beginning, the middle, the end, and as we actually practice the service as well.
Rachel, did you have anything you wanted to add?
Yeah, I would say in particular, we did a focus group and a survey with deaf communities and some individual interviews with autistic folks, and a focus group with folks with developmental disabilities. And what we did to make that happen, we really wanted to connect with organizations that were already serving those folks, where folks already felt safe and comfortable. So we connected with the largest organization in Toronto that serves deaf folks and particularly provides mental health programming, and they co-facilitated the focus group with us and publicized our survey. So we really, when we were thinking about autistic folks, we reached out to the Autistic Self-Advocacy Organization in Ontario. We really didn't want people to feel like we were making them come to us in a way that would feel inaccessible to them. We really wanted to go to them and get feedback from them and from the folks already doing this work about how to make this environment and this space accessible in order to get that feedback.
Thank you. Dr. Martin, I guess I have a question for you in that understanding the relationship of the nurse and the police officer in the intervention that you were speaking about. How many hours a day are they available over the course of, of a day? And are there times, in other words, are there times that are more advantageous that they're not available than others?
Thank you. Yeah, I mean, it's a good point. Initially, the VPOP particular program was only available 2 days a week. So because they were the same staff who were engaged in the mental health response unit. Now, because again, that was a sort of a pilot with this provincial grant, And now they've expanded it, like I said, so that it's available every day. So every day there will be both a nurse police team who will do response to calls, and then a nurse police team who will do proactive connection and follow up with community members. And sorry, and then in terms of hours, so it is every day on every platoon. They do end at, I believe it's 2 a.m. So there's no coverage between 2 a.m. and 7 a.m. But they also thought that they tried to match it with community resources, that a lot of our community resources aren't open 24/7. And so even if they were running all 24 hours, that they would be taking folks to the hospital or having to rely on other services. So in our community, it was more dependent on our community availability of community resources.
Is there any special relationship that because there's a nurse involved that you have with the hospitals?
Yes, so they allow, it gets them direct access to our emergency room, access instead of waiting. And also because the nurses they're actually employed by the hospital. It's just a partnership with our police service that they can then access and support folks with their electronic health records. And so that sort of facilitates treatment, being able to connect with their caregivers or information that would support intervention with them.
Thank you. Rachel and Asante, have you all found that the community itself has taken more ownership of engaging with people with who are in mental health crises and identifying those people and directing those people, to services?
That's a tough question. If what you mean is if the community is organizing themselves, I'm not so sure. But in terms of our engagement with community, and since the city has taken up the mantle and went forward to also engage with community members, there has definitely been a lot of momentum and a sentiment from community members where now they feel like they have power and they feel like their words matter and they feel like they can help shape the change occurring in their city, which is, in Toronto, there has historically been a lot of bad faith for, municipal processes and how those things operate. The refrain here is that change will never come. Politicians don't care, probably common for a lot of different cities, right? So, but with this particular issue, there has been somewhat of a shift. I mean, there's still a healthy amount of skepticism, I would say in terms of even with some of the folks that we engage with our organization, but that skepticism is less than what I've seen in the past, and I think slowly diminishing as the results are starting to emerge, but still a lot of work to be done there.
As we end this session, I'm going to put this question out to all of you all, and with respects to what do you see as being the biggest challenge confronting, what you're doing from your perspective?
Resources.
Misinformation and old narratives and stories that are fiction, but people really believe are reality.
Okay, can I use the word stigma? Stigma. In addition to that, okay.
And I think actually competition for funding. I would say that sometimes, I've heard a different panel about having a system of crisis response. And I feel like in our community, we don't have a system, that there's these community groups, including our police service. And so there's all these groups, and our system needs to be a system.
No, I hear you. Loud and clear. I think that everyone is trying to figure out a way to overcome that. There are three things that keep a system from being a system, and one is technology. There are so many different approaches to technology, especially information, how people access information. The next is processes, whether it's funding, whether it is rules and regulations. There's a big gap always that people are confronted with. Last but not least, decision making. who's in charge. And I think that we oftentimes, end up being our own worst enemies because we end up, fighting battles over turf that we don't really have. So that can be a challenge. So, but I really want to thank all of you all for the contribution that you've made, this afternoon, for this workshop and around the area of law enforcement and mental health. I think that there's a future. And in fact, I hate to say this, I think that COVID has opened up a door for us to take a look at, really, making some quantitative changes in how services are delivered and how we are engaging, the populations that we serve. So I want to say thank you to all of you all, very much again. And I also want to make sure that you leave me some information so I can reach out and hassle you about, getting some more information about what you're doing and hopefully bring it down here to Philadelphia to reinforce what we're doing. Because by the way, a lot of what you're doing is actually validating what we're doing down here. So thank you very, very much.
Thank you for having us.
Yeah, please. The honor is ours. Rashid, are we okay, or do we need to do anything else?
Nope, you guys are all set.
Okay, so you guys are done. Enjoy the rest of the conference.
Take it easy, everybody. Enjoy.
And it's a pleasure, by the way, Asante.
Thank you, man. It's a pleasure.
If you're ever in the area, look me up.
Where you at, Philly?